Wonderful. Well, welcome everybody. We are, again, welcome to all of our friends and colleagues who are visiting us from Kenya, from Aga Khan University, from the Kenyan government, the Ministry of Health, and the National Bureau of Statistics, and from the Kenya Medical Research Institute. We're thrilled that you're all here with us here in Ann Arbor and at University of Michigan. We're also thrilled to be hosting today a collaborative Center for Global Health Equity and longitudinal study of health and aging in Kenya, a roundtable focused on global health and population aging in low and middle income countries. Before we get started, I'd like to give a big thank you to those who've helped organize this roundtable today, which required a lot of work, particularly Kelly, but also Jana and Christina and Rachel. We're excited to be able to have this discussion today and to draw on the brilliant minds that are here with us and who bring unique and important perspectives to this issue of ever increasing importance. My name is Josh Ehrlich. I believe I know most of you. I am one of the principal investigators of the longitudinal study of health and aging in Kenya, or LOSHAK, and also an associate director of the Center for Global Health Equity, faculty here at the Institute for Social Research, and also in the medical school. And I'll be moderating today's discussion. I'll provide a little bit of intro to the discussion, and then perhaps we can go down the table and everybody can give just a brief introduction of themselves, name, institution, and your role here today. To introduce the session, aging, we know, is a global phenomenon that's affecting local populations throughout the world. This panel, again sponsored by the Center for Global Health Equity and LOSHAK, brings together experts from the University of Michigan, Aga Khan University in Nairobi, the Kenyan government's Ministry of Health and National Bureau of Statistics to discuss issues relevant to studying population aging and health in low and middle income countries around the world. We'll discuss a broad range of issues related to fielding population surveys, community engagement, reciprocal partnership building, and knowledge translation to shape public policy and other key issues. And with that, I'd like to open up for my panelists here, fellow panelists, to introduce themselves. Again, just name, institution, and your role here today.
Hello, everyone. My name is Akbar Walji. I am the director of the Center for Global Health Equity. I'm a physician scientist, also a gastroenterologist by training. A lot of my work revolves around using technology for in low resource settings and leveraging that data for better health and longer life. I'm happy to be here today representing the Center for Global Health Equity, and thank you for this great panel.
Good afternoon, everyone. My name is Muthoni Gichu. I am a medical gerontologist and a scientist. And my main role is around promoting healthy aging and also seeing to it that we advise the government in developing policies that support healthy aging and older persons' health.
Hey, everyone. I'm Ken Langa. I'm a professor here at the University of Michigan in general medicine and here at the Institute for Social Research. I'm co-director of the Health and Retirement Study and also the co-director of the HCAP International Network with Lindsay, who you'll meet in a second. And most of my work has been on dementia epidemiology.
Okay, good afternoon. I'm Melas Nyaga, working for Kenya National Bureau of Statistics. I'm actually a demographer in the Bureau, and I usually manage health data. Thank you.
Hi, everyone. My name is Lindsay Kobayashi. I'm an associate professor of epidemiology and global public health at the School of Public Health here at the University of Michigan. I'm the associate director for research of the Center for Global Health Equity, co-director of the HCAP International Network with Ken, and I'm a co-investigator on LOSHAK, co-leading its HCAP sub-study. And my research, as you might have guessed, is on the social and economic determinants of cognitive aging and dementia around the world. Thanks.
Hi, everyone. My name is Anthony Ngugi. I'm an epidemiologist, professor of epidemiology and population health. I chair population health at Aga Khan University, East Africa, as well as an associate dean for research in the medical college. And I'm an MPI of LOSHAK together with Josh. So I'm so heavily into aging research. I do other things such as developing long-term population data platforms and cohorts, and a number of other things related to climate and health as well. Thank you.
Hi, everyone. I'm Emily Briceño. I'm an associate professor at the medical school at the University of Michigan. I'm a neuropsychologist by training, and I'm a collaborator on the HCAP network. And my interests are in measuring cognitive aging in culturally sensitive and comparable ways around the world.
Hi, I'm Bill Axon. I am the director of the International Research Hub at the Institute for Social Research, created by the Survey Research Center and the Population Studies Center. I'm on the faculty in both of those centers, in sociology and at the Ford School of Public Policy. Look forward to talking in any useful way I can that might have to do with survey methodology or World Mental Health surveys or something that is not aging or HCAP.
Great. Well, thank you all. And I thought we could get started. Perhaps talking a little bit. You feel the information, the policy be preparing.
Pretty interesting. So there is the policymakers, and when you talk about the policymakers, who are they making the policy for, and where are they making the policy? So for us to have any kind of planning, whether it is for health services, social services, development, it is important to understand where our population is looking like and how our population is looking like. And so, for example, if we're able to know the health status of our people as they grow older, then we get to know who it is that utilizes health services more than who, and what it is that we can do to have a healthier population. And that is one aspect of things. And then from a country point of view, how do we prepare for the social security of people as they grow older? Because again, over time, we have learned that we can only be in the job space for so long. So what happens when that time comes to an end? So does that mean that when your income stops, your quality of life and the health that comes with it has to also change? Or how do we support and cushion people in that space? And then when you look at development, when people grow older, how does our economy respond to their needs, one, and the opportunities? So when people, for example, retire, if at all they do, or when they feel they cannot be in the job market anymore, what else is there for them to do? How do we identify opportunities that allow us to keep people active for longer and healthier?
Anybody else here to add anything to that? Feel free to chime in. We can pass the microphone down. But I might ask specifically, Bill, drawing on your policy experience and your role in the International Board School, do you have any thoughts from the context where you've done work?
Yeah, I mean, I'm certainly in the data to help consider, design, evaluate policy end of that spectrum. I respect that every population, I'm a demographer by training, so population aging was very forecastable, and yet here we are dealing with it everywhere on Earth as though we weren't prepared. And it is hard everywhere to prepare ahead of time for things. And given that we're dealing with demographic changes, I love you ending with that economic point. It's forecastable that there'll be more people alive at those ages and that they'll live for more years. So what it means in terms of every kind of health need, my own work, Josh, I guess, is a little bit focused on mental health, which I have learned is linked, maybe not causally, to dementia, Alzheimer's, and those kind of issues, but is certainly linked to quality of life, ability to do things. Both social things can help with that quality of life and avoid mental illness issues, but staying mentally healthy can make you more active and more productive. I think these complex reciprocal relationships in throughout life, but especially in older ages, require longitudinal data, which we're really good at making here, and then applying it to the specific policy needs of a place. I kind of want to punt to the HRS folks because I'm not convinced that the whole world is the same on this, but maybe we are. I don't know.
Yeah, no, I think it's some interesting points. And I mean, Ken, if you wouldn't mind sharing your thoughts.
I think, yeah, all the points made so far are right on target. This is probably an obvious point, but it has felt to me on the HRS that if you do want to study this complex processes with bidirectional causality, the aging process, in a multidisciplinary way, which is what sort of the HRS has been kind of trying to do from the start. Our ultimate challenge, including for the LOSHAK folks that are starting up the study, is trying to prioritize how do you collect as much data as possible, yet not spend $1 zillion and not burden your respondents in a way where they give up on you and want to leave. So, that's in some ways throwing up your hands because, I think everything about health, family, environment, et cetera, is going to be important for trying to understand these various processes and inform policies. But ultimately, again, the challenge for all of us in these longitudinal studies is trying to prioritize and really collect these kinds of data in a cost-effective way that will allow us to make sense of them.
So I guess building on that, to you or else in the panel, once we have good data, we've collected whatever data in a parsimonious way we feel are appropriate for the context. How do we use those data to benchmark how a given place is doing in preparing for the aging of their population and addressing concerns and challenges related to that?
I can respond, but in a slightly different direction from what you just posed, Josh. Kind of going back to your original point about social welfare and public policy, like what do we do to ensure social welfare of people after they retire, and building also on mental health, Bill. And also to your point, Ken, about how do we use data efficiently. I think one nice example is I lead a program of work looking at cash transfers and social protection policies in South Africa as a data linkage project arising out of the Halsey study, which I think some people here are probably familiar with. It's part of as part of the HRS network. Halsey is interesting because it's regionally representative, not nationally representative. But this also brings about some opportunity because Halsey samples out of a health and sociodemographic surveillance system, which I believe there's also more than one in Kenya, right? And I'm not familiar with any Kenyan HDSS platforms, but the one in Agincourt, South Africa, where Halsey runs from, has many, it serves as a platform for multiple research studies. And we were able to link the Halsey cohort data with data from other studies that were done prior to Halsey through common identifiers on the HDSS. So if there are any local opportunities within the LOSHAK sampling frame broadly, and again, I don't know, these are probably contingent on aspects of the national sampling strategy, which I don't know much about, and we can have those conversations in more in-depth ways over the coming days. I think those types of data linkages are really valuable, as well as taking advantage of any national or regional policy changes. And so those were two things that we did in Halsey. There was a randomized controlled trial of cash transfers directly to households embedded in the Agincourt HDSS that ended right before Halsey started its sampling, and there were overlap in these sampling frames. We were able to link them. So this was just something that was very fortuitous, right? And we were able to reanalyze those cash transfer data. So households in the treatment arm received a monthly cash transfer for up to 4 years. Households in the control arm received nothing. And then we were able to reanalyze that RCT data in relation to any aging outcome in Halsey. And we have looked at mortality, memory decline and dementia risk. And I think this is some of the strong, and we saw like really meaningful effects with respect to receiving the cash transfer intervention and slowed aging related memory decline and reduced dementia probability. Like the cash transfer intervention completely offset the normal pace of aging-related memory change over the 7-year follow-up. So I would absolutely encourage you to look for sort of like fortuitous opportunities for data linkages in LOSHAK, whether that's at the national or the local level, you know, in specific places. And again, we can sort of talk more. And we've also been able to leverage changes, for example, to South Africa's pension policy, whereby it became more generous for men by lowering the age of eligibility. And we've done like a number of follow-up studies, and that public pension in South Africa, and this is a very low-income rural region, unemployment rates are very high. There's a lot of multi-generational households, largely due to the HIV like epidemic, right? Where sort of that middle generation was hollowed out, a lot of grandparent, grandchild caregiving. Older adults like in that region are very economically productive members of households because they're receiving a generous public pension and supporting many family members through it. And then kind of tying back to mental health bill, we are currently working on looking at some ancillary health effects of this randomized cash transfer. And we are finding that older adults in the Halsey cohort study who were in the treatment arm of this cash transfer trial actually had worse mental health at the conclusion of the cash transfer intervention. So both kind of initially when Halsey did its baseline, immediately following the end of the cash transfer, as well as over time. And this sort of like confounded us, like it went counter to what we think like improved income should do for health, right? And what we think we're actually seeing is the impact of losing that monthly cash transfer. It's the loss, right, of that additional monthly income. And we did a little bit of digging into mechanisms. We looked at household dynamics in households in the treatment and control arms of the trial. And we saw that households that were in the treatment arm of the trial actually had new household members come in, like extended family members who could use that additional financial support. And then fast forward, the trial ends, that income is lost, but you still have additional household members to support. And so that can put quite a lot of strain on people. So what we're sort of seeing, like I'm a big promoter of social protection policies in general, but public pension programs I think are something that we can advocate for. And I would very much encourage like us and the LOSHAK team to think about creative ways to evaluate policy, whether that's through, you know, potential quasi-randomized like, impacts of policy changes, pension changes, or local opportunities. That's been something that's been really valuable that we were able to do in Halsey due to its nature of being embedded in HDSS. And I'll end there.
Great.
Yeah, maybe if I can add just briefly onto that. If you, I think if you look at the Kenyan health statistics for the elderly are conspicuously absent. Yeah, when the national health statistics for most part disaggregates data, they actually disaggregate for all other age groups, children below 5 years of age, including maybe infants, children below 1 year of age, children who are neonates, women of reproductive age, men 15 to 54. But when they actually aggregate data present data for the elderly, they actually do it 50 plus, and that's it. So a lot of conditions that affect only the elderly are actually missed because of that. You find that, for instance, Alzheimer's disease, dementia, we don't have any data. If, for instance, the data that's available on prevalence estimates is based on very small sample sizes. Yeah, we don't have data on exposure, both socio as well as biological, and that's why, for instance, collecting biomarker data is very important. The exposures that you would actually hypothesize are associated or causal for some of the cognitive outcomes that you're studying in these studies. They're actually very different from many other places. For instance, a lifetime of exposure to various infectious diseases, in exposure to lifetime poverty, hard labor, and so many others, including nutritional pressures. Yeah. So studies like LOSHAK and many others that are coming up in many parts of Africa, there's a number of pilots that are coming up as well. actually going to provide very useful data for policymakers, data that is nationally representative, that is biomarker enriched, that is that has got a lot of detailed cognitive assessments and measurement of so many other exposures. Yeah? This happening at the time that the demographic transition is happening so rapidly is very, very timely. Yeah? And having this sort of collaboration with people who've done this for many years within the HRS, HCAP network is really a boon for all of us. Yeah.
Thanks so much, Nick and Lindsay. I think those are all really good points, and certainly so policy relevant, some of the work that's being done in South Africa with your group and Lindsay. And I agree more that LOSHAK and other studies coming online are due to make significant advances in what we know about policy data. I think that's actually a really good lead into a question we have for you, Elias. How can low-income countries, based on your experience at KNBS and your understanding, strengthen data systems to better understand and respond to aging populations?
Thank you for this opportunity. Yeah, I think for one, we know that in most of our, like Kenya, as one of the LMIC, we normally concentrate on getting demographic information. Maybe when like we are conducting censuses, we collect information on just demographics. So what I would think would be the best thing to do is better collect, data which is actually enriched. What I mean by that is that maybe for our national surveys, why don't we have some modules whereby we are collecting some data on the older population? Like if I may give an example, when we are doing DHSs, our focus is on reproductive age, which is up to 49 years. So we have been trying to emphasize that why don't we go beyond that and actually collect data which has an aspect of the elderly. Then another thing is we have never focused actually on longitudinal studies. Actually, the last one that we did was actually on reproductive health, which was in around 2012. So actually, if we can emphasize on conducting longitudinal studies, it actually will give us a good direction in terms of social inclusion, more so affecting the older persons. Then the other area that we have not focused on is as LMIC should be administrative data. This is actually data which we normally generate on a day-to-day basis. But you find that it's actually quite scattered, far apart, and it doesn't speak to each other. So you collect the survey data, population data, and administrative data, but there's actually no good linkage. Now that takes me to the next level where we should have some partnership, so that the researchers, the government, even the NSOs can come together, have some linkage so that that data can now be linked such that we have something which is speaking to each other. But as at now, things are far apart and is not speaking to each other. So I think those are the key areas that we really need to focus on. Thank you.
Any other thoughts or comments on Madoni?
Can you tell me what NSO is? Much more for this.
One thing that is unique about LOSHAK is that it is bringing very many people on board, from researchers to government. And this should be a place where we can actually model what this knowledge translation looks like across board.
Yeah, so I was going to say one other way in which you can actually strengthen data collection and actually embed it within the National Health Information System is through a model that we can actually borrow from the work that we do in Kaloleni and Rabai, whereby we engage community health workers to collect data using government health management information system tools at the level of the household. They're actually very well trained. They become very, very proficient in capturing this data. Muthoni will tell you that she actually designed a module in one of the other tools that we call MOH 514, which is about following up on referrals and identifying people who need to be followed up for instance, for immunization, for nutrition counseling, for antenatal care. There's a module that is there for identifying the elderly in the population, and actually, maybe you can correct me if I'm wrong, maybe doing very simple basic screening, capturing that information, and then referring them appropriately upward across the chain if they have, and in fact, I think the recommendation is actually to have them seen every 6 months for health assessment at a health facility that's nearest to them. So there's a system that can actually be leveraged. It's already there, but it can be strengthened to actually collect this information on an ongoing basis. In fact, I've been talking to a few colleagues, and probably that's one of the spin-off studies that you can actually get out of this. Yeah, and then at the level of primary care, our experience is that during the pilot, we actually worked with the local health workers, that is nurses and the clinical officers, as well as the local laboratory people. We're actually able to do very good screening using these HCAP tools and the other tools that we're using, and collect the data that you actually saw, that we analyzed and we've published. Yeah. So the level of health facility primary care can actually also be strengthened to capture this information and generate it in a way that is of high quality. Yeah. So are some of the other areas that we can actually add in terms of strengthening data capture, so that we actually don't just have to wait to do a LOSHAK survey every 5 years, but this can actually be a norm, that is data that's possible to capture at the health facility and at the community level. Thank you.
I just wanted to say I'm jealous. What you're already having a discussion of is so important, and I wanted to emphasize the point of the conversation itself is so valuable. I launched a study in Nepal in 1995. It's still going on today. Lovely for many of us who do the science. But maintaining engagement with government has been virtually impossible across that period, and partly because they've never been at the table with everybody else. And I think having all the partners at the table is a really important fundamental ingredient to making that work. Maybe no matter what data we create, I'm not sure. Josh, the one thing you and I have in common is some background in anthropology. And one of my favorite discoveries in our mental health work in Nepal was a specific program that was designed for another purpose, a little bit like Lindsay's commenting on. It was an intervention called the Small Farmers Development Program, created by the Food and Agriculture Organization of the United Nations. It gave microcredit loans to farmers, and instead of collateral, the farmers were jointly liable for it. Sociology, that's not social support, it's social cohesion. Social support might be telling you you're doing great no matter what. The social cohesion in this case is, no, stop gambling. That money belongs to all of us. I need you to stop gambling. I need you to stop drinking. I need you to, we're in this together, and I need something back from you, not just I'm here to support you no matter what you do. That we demonstrate that program, neighborhoods that had that program, adults after the armed conflict have major depressive disorder at 50% the rate of neighborhoods that did not have such a program. It's not a randomized controlled trial. Lindsay, you threw that word around. I appreciate it. But I think you can make use out of something that was outside of the control of the neighbors, villages, whatever you have. Sorry, I don't know Kenya at all. I'm sorry. I apologize. But whatever the local structure is, if it's outside of control of those people, you can still use that to a useful end in trying to evaluate different interventions that might have been done for completely other purposes. And maybe you have an opportunity to discover something that works locally. Anyway, very jealous. Wonderful conversation.
Those natural experiments are, without a doubt, conceivably important. And the other point you made that I can't overstate the importance of is our government partners at the Ministry of Health, at the Bureau of Statistics. Not but actually intellectual partners. Yeah, yeah. So kind of sticking with that theme of data and data science, I'll ask our other data scientist at the table if he could start us off talking about whether you feel that Africa and Kenya in particular, where I also do work, Akbar, can leapfrog research and healthcare systems here in the West and high-income countries in terms of developing and using AI-enabled tools, and kind of what the risks and opportunities are.
No, thank you for bringing that up. Again, there's a lot of buzz around AI and the use of AI, and everybody's talking about AI, but it's just one more technological advancement, right? And I think we have to be really cautious when we're thinking about AI and what it can and cannot do. But in the same way, when we talk to the National Bureau of Statistics and how we have so much data now, right? It's administrative data, it's health-related data, but now it's a natural extension of all the data that we're collecting on ourselves. It's this tsunami of data that's coming at us, and we don't even know quite what to do with it. But AI is a tool that could potentially leverage insight into some of this data in so many different ways. And I think Kenya, I think Africa as a continent has such a great opportunity to kind of leapfrog in ways that they've done before, right? M-Pesa, an example in Kenya, mobile money is the translation, has done so much when they went from rotary phones and banking systems to now doing transactionals every single day. Can we do that in some different way with the data that we have, leveraging AI and leveraging technology? Now, we want to do that again, and I keep on reminding myself to put that disclaimer to say that we can't forget the human behind the advancement of technology, because that in itself can drive inequities. I'm sure there are people out there that can speak more about what the bad implications of M-Pesa have been, right? But at the same time, we have to just be conscientious about that. And so I think the opportunities that exist where we can leverage this data is maybe even think and push the boundaries of why we're collecting this data. And are we using even chronological age as the benchmark of aging? Is there other things that we should be thinking about? Is a biological age something that we should be reflecting on? And then, thinking about, the body is more holistic and not Alzheimer's alone, without thinking maybe there's a gut peptide that influences Alzheimer's-related diseases. This is all new insight that can emerge with using some technologies, using some innovation, that maybe it pushes our boundaries more than the traditional ways of looking things. And maybe there's this more inclusive insight. Yeah, it's high risk, but I think there's a potential there to bring more insight and drive generating new hypotheses around leveraging this data. I think that's something that I'd like to see to uncover when we have such rich data across the entire world, right? I mean, this is such a longitudinal study that could be harmonized with data across the globe. I think will take us in a different way. And I think we should just be pushing the boundaries there.
I think that's really exciting to be thinking that's innovative. Textually what matters, but also what matters locally and specifically. Any other thoughts on that topic before we? So I have a question I want to.
You can certainly tell me that I'm crazy, but that's.
So kind of changing gears a little bit, Anthony, could you talk to us a little bit about some of the lessons that LOSHAK learned during the pilot feasibility phase of the study with respect to adapting cognitive measures to the Kenyan context?
Yeah, I think one of the issues that I think comes up a lot is probably there's always been an assumption of universality of measures, yeah? That measures developed in one place can actually be applied to other populations with what we would call maybe surface level adaptation, yeah? And I think probably maybe that tends to get conflated with universality of the cognitive construct, for instance, because memory of how I remember my pet when I was a child, my first dog, is more or less the same way that a child in America would remember the memory, the first pet, yeah? So the mechanisms of remembering memory are the same, but so you can assume that is universal. But when it comes to the measures themselves, how do we measure this concept or construct of memory? I mean, I think it differs. For instance, in LOSHAK, when you are doing the adaptation, cognitive interviewing and all that, some of these came to focus. For instance, this test of clock drawing, which is supposed to be a measure of executive function. Yeah. When it's an analog clock, yeah, which is used in the West, for instance, in HRS and maybe other places like LCNE in the UK, you find that most of the people will not be able to do that. Yeah. And that is not because they do not, they're cognitively impaired, but it's because they actually do not have any exposure to analog clocks. They are maybe more familiar with a digital clock, and actually that's what we saw a number of them drawing. Yeah. So if we went ahead and used that test to test the executive function without proper contextual localization, then you'll actually not be measuring the construct of executive function. You'd be measuring cultural exposure to Western concepts. Yeah, and that goes on for a number of others. For instance, logical memory. When you have a story that talks about, developed in the West in HRS and other places and works very well, that talks about, for instance, a man walking down the road and finds a house that is on fire. He picks a fire extinguisher and starts putting out the fire and calls fire department. So if you applied that, the terms that are used in that story that you're trying to test memory, they actually have no cultural salience in our population. Yeah, people do not know, for instance, in the rural areas, what is a street? Yeah, what is a fire extinguisher? What is a fire department? Yeah, so again, you actually have to adapt that to something that is relatable in the local context. Yeah, so the issue of adaptation is very key, and that's why we're actually spending a lot of time making sure that we have the proper teams and the proper mechanisms of adapting the tools to our cultural context, and not just at the surface level, even going ahead to do what called deep structural adaptation, that where we want to maintain or aiming to maintain the same factor structure with locally adapted items.
Great. I wanted to ask Emily if you could share a little bit of your experience, because you do so much of this work, thinking kind of generally beyond our context in LOSHAK, with all of the studies with whom you've worked, kind of what some of those principles, the challenges, the opportunities are for developing and validating cognitive measures in some of the studies you work with.
So first, I really appreciated all of Anthony's comments. And I think the LOSHAK team has done an outstanding job at really carefully scrutinizing and identifying some of those measurement assumptions that aren't appropriate for the local context and finding solutions to those. The work that I've done in adaptation has primarily been in Nepal and now ongoing work in Guatemala. And we've had a lot of similar observations and have done, had a lot of similar challenges, right? That a lot of the tools that are prominent to measure cognition and cognitive aging have these baked in cultural assumptions about exposures. So a few kind of common ones that we've seen, and I've heard from colleagues, tasks that require drawing, right? So the clock drawing is a good example, not only of the actual clock, but of the experience of using a paper and pencil and drawing, right? To show ability in things like visual spatial functioning, executive functioning, and even processing speed. So processing speed, for example, is a domain of cognition that's so important in the context of aging, right? We know that it declines with aging. We know that it's sensitive to pathologies like cerebrovascular disease and even Alzheimer's disease. And so measuring that change in processing speed is so important. But the predominant tools for measuring it require the use of a paper and pencil. and they require that cultural assumption of familiarity with going quickly, right? That there is a task in front of you and you're expected to be familiar with that speeded responding. And so those are the types of things that have that we've encountered and looked for solutions for. And I think that the HCAP network has such a great opportunity in that the framework allows for adapting existing tests that allow us to do cross-national comparisons, and also thinking about developing from the ground up tools that are developed for a specific context, that maybe are, designed to measure a construct in a way that's locally appropriate and valid and accessible. And those measures can be developed alongside these adapted measures. And then they all can be used to measure cognition.
Thank you. It's so helpful. And I thought, Bill, maybe could you say a few words about mental health studies, how we kind of
Can't resist. Yeah, thank you. Thank you for talking about that work. So Emily and I both work in Nepal, and as she was describing the paper and pencil in the Nepalese context, I can't imagine anything other than a 30 to 60-minute conversation about why you're asking us to do this with a piece of paper and a pencil before we even start asking the question. I don't know how you would use speed to measure cognition in that context. Yeah, I hope we can find some ways to link what we're doing with the World Mental Health Surveys with what you all are doing with the HCAP network, with LOSHAK. I don't know what those opportunities are. I think you spent some of today with Stephanie Shardul already. I think you're spending a bunch of this week with Stephanie Shardul. She and I are the co-directors of the World Mental Health Surveys, just transferred to us last year from Harvard. They've been an immensely powerful global resource for studying mental health in some of the ways that we were just talking about in these comparative cross-country ways. It's a different structure of validation, and I think it was David Weir who first taught me this, saying that Ron Kessler is the inventor of this survey. It's a very rigid protocol. It's grounded in DSM and ICD criteria, and the quality for this test work is whether a clinician gets the same answer or not. And so there's a clinical reappraisal, and that was such a tremendous process. I got into it from a survey methodology perspective because the World Mental Health Surveys had never succeeded in South Asia, been tried in India 3 times, in Nepal twice, never succeeded. And I love that kind of problem. I'm not sure what disorder that is, but I love that kind of problem. And we embraced the opportunity, and it took us 4 years to create a clinically validated version of the World Mental Health Survey for Nepal. And we limited it to 9 disorders. That team normally measures 35 disorders. And it's in the context of a longitudinal study. I know that a 3-hour interview dramatically reduces the odds of doing the next interview. People will no longer comply. So I refused to do that. And so we were forced to limit the number of disorders. And I think there's big differences across these disorders. Those of you who are professionals in these areas understand that better than I do. But it's a wonderful opportunity to say, okay, if we want general population measurement, which I'll bring back to the policy domain, which we can use for evaluation of the investments we've made or discovery of new interventions that might help, then we need a tool that we can do with interviewers, not just clinical professionals. And we need to be able to do it in a way that represents the full population in some kind of systematic sampling approach. And if we can do that, it gives us a tool to use to evaluate how things are going across time and potentially identify things that aren't clinical treatment that help. And I think I've written the phrase in proposals, which you all must know more about, that Alzheimer's and related dementias are a tidal wave of public health problems. My favorite story, those of you who are MDs here might not enjoy, in Ann Arbor, Michigan, if you're new to Ann Arbor this week, it's not a big city. If you've been to the hospital, it is a big hospital. We have a big department of psychiatry with a lot of wonderful psychiatrists there. If you have a child with a serious psychiatric problem, anybody want to guess out loud at the waiting time in Ann Arbor, Michigan to get your child in to see somebody in the Department of Psychiatry? Those of you who've tried already, it's not fair. It has to be somebody who hasn't tried already. Anybody got a guess? That's kind of scary, but the truth is 12. And I tell this happily in a place like Nepal, where there are 40 million people and fewer psychiatrists than sitting across the street in that hospital. If we cannot take care of the kids who need that kind of help in Ann Arbor, we're not going to be able to treat everybody who needs help. And so for me, not an MD, not helping on the clinical side, I'm always looking for what are the interventions that I could discover that might reduce the rates of these problems to lower who we need to treat and reduce the burden of treatment. But I think that total prevalence, burden of treatment, compliance with treatment, all those kind of things are great things to get at the general population level in a way that fits the local culture, whether it involves paper and pencils or not. So that's my 2 cents.
That's great. Really diversity of perspectives there. I think that leads us into another issue that I wanted to discuss. Lindsay, maybe you could say a few words about this tension that sometimes exists between localization and harmonization.
Talk about this kind of on a general scale and specifically around cognitive harmonization. I think Anthony and Emily spoke about cognitive harmonization really well, and I think we have tools both at the design stage of research through the data collection and data analysis phase to help ensure that we have, and like Emily calls it construct centered, like adaptation, right? To like very carefully and thoughtfully adapt our measurement tools so that they are appropriate to a local context, but maintaining measurement of the same underlying construct, right? And that works in the case of like human cognitive function, which we think at a basic level is a universality across populations, right? I mean, we're still learning more about the brain every day. That might not always be the case. And I think these studies like LOSHAK are going to help us understand more and more about the brain, like the development of cognitive aging in contexts, you know, with complete absence of different exposures or different distributions of exposures. So I think actually this is going to be like a major innovation. I think that harmonization becomes more challenging when you're trying to measure constructs that are not the same across settings, right? Or think about different types, like think about how one type of policy intervention might be adapted to another setting, right? There's going to be a lot more sort of levers where you're going to have to make decisions and think about how to harmonize. And I don't really have an easy answer. I think with respect to measurement, you know, the Health and Retirement Study Network has done a really good job with harmonizing, you know, a range of measures across their surveys around the world. And I think that's really valuable. And then with respect, and another way that I like to think about harmonization, you know, or thinking about sort of that like local global interaction is like one of the outcome is with respect to what is the outcome that we want to achieve by doing harmonized research, right? And I think we want to think about different lessons that we can learn from one setting and apply that to another setting. And that's something that I think is very bidirectional and increasingly bidirectional, and even like multi-directional, right, across different studies, because that's a major innovation that this international network lets us do, right? And so I think, I think that we as a field and like this team here can make a lot of innovations with respect to how we do that type of work in practice. I think we can think about it from like a research methodology and analytic approach, and we're starting to make some of those innovations with, at least within the HCAP network. For example, we've published work on like analysis strategies for harmonization and drawing conclusions across different like modeling approaches. And that's one way to think about it. But I also think there's just a lot, there's a lot of room for innovation in terms of the different types of, whether that's individual level exposures or factors like contextual, like local, regional, national environments or policies, and how do we get those measures? And then how would we think about then applying it to another context? And I think that's a situation where you need interdisciplinary teams and you need kind of the right people at the table. So for example, having government partners involved intellectually, right, not just technically, is really important, because then that way you can think about implementing, like designing and implementing potential interventions sort of like from the get-go that are based on learnings from other contexts around the world.
Great, thanks. Elias, I'm curious, as somebody who needs a lot of data collection and has a lot of experience in that domain, if you had any thoughts on this sort of localization versus harmonization potential tension? Yeah, that's okay.
Well, I don't know whether I got you collected, but what I think is more so if I focus on ROSHAK. Yeah, I think the issue of localization actually is very important because from the data collection point of view, people really have to understand the concepts. So if you try to collect data at the level in which maybe it's at the international level, you may not actually collect the actual information that is required. So this is why localization is very important, so that once you are asking for this particular information, then the people out there are able to understand and actually provide the right information. The essence of doing the whole thing is actually collecting the right information. So this is why localization, I mean adaptation and localization of the tools or for this particular activity are actually very, very critical, so that you collect the right information. I hope that's the question you asked.
Absolutely.
Yeah.
Any other?
Like bringing it into that space. So we talk about harmonization because it needs to speak to other similar studies. We talk about localization, but we also need to talk about the standardization with the localization.
Can you say more about that, please? I know you and I talked about it earlier, but everybody here might not.
Yeah, so once we have localized it, are we looking to make sure that the level at which we localize it, it actually speaks to what Elias is talking about? Does it speak the same thing across different populations or different contexts in a similar space? So when we have that tension on localization and harmonization, then we need to also consider the standardization, because it affects the harmonization part of this.
Absolutely. And I think that point is so well taken, particularly in a context like Kenya that is so heterogeneous. Yet we want to measure things in a way that's harmonized outside of Kenya, but is standardized and localized within Kenya. So I think that's a point very, very well taken.
Yeah, I think it's a very interesting question. And as Lindsay said, I don't think there's a ready answer from this panel or from anybody else, because I think the tension that exists between harmonization and localization, I mean, from where I sit, I don't think it's a bug that we need to fix. I think it's one of the features of working in comparative aging science. Yeah, I think it's what keeps us going to try and improve our methods, our tools, and this will go on. I mean, like, so for the foreseeable future, we'll not be able to resolve that. Yeah, but it's true. I think harmonization does place some constraints on localization. But I think the level of the constraint is actually dependent on what research question you're asking, as Lindsay mentioned. For instance, you might be interested in addressing very localized research questions. Yeah, let's say you want to compare how a test, like let's say for memory, whichever test you want to pick, you can choose. How does it function across different demographics within a particular country? Like let's say Kenyan. How does a tool or a test function across rural and urban, or does it vary by education? Does it vary by the interviewer, and so on and so forth? Yeah. So there you can actually sort of bend towards more of localization. But for questions or research questions that are explicitly comparative, yeah. For instance, you want to compare the factor loadings in your confirmatory factor analysis onto some memory tests. How do they load onto memory construct, yeah, across different studies in Kenya, in India, in South Africa, yeah. For the answer for that question to be meaningful, then harmonization should be a precondition for that. But I don't think there's any sort of like really clear cut with just a balance depending on what question you're trying to address, more or less. Yeah.
Great. I think, Bill, you wanted to say something to say that I love some, Anthony, this is something to fix, right? This is something to navigate. I think you're absolutely right. It's not a feature that has to be fixed and solved.
Anthony, I was moved by exactly the same thing. No, I had a different take on it, Josh, but I agree that fixing it is a little interesting. Sometimes I say I don't do international work. I work in the United States and Nepal. In the United States and Nepal, there's a big local difference between what's locally correct and what's nationally correct. Survey Research Center right now is doing the New York City housing study in 11 different languages. We have interviewers working in Cantonese and Mandarin both. And that's in New York City. In Nepal, there are 75 mutually unintelligible languages. I'm embarrassed that the only way I know the size of the country is in miles and not kilometers. How bad is that? But it's a small country with not very much arable land, actually, and 75 mutually unintelligible languages and very different cultural practices of all aspects. I mean, thank you for bringing up the gut, Akbar. I don't know what you know about guts, but I do like to eat, and I know that people eat very different things in different climates and different places, and yeah, waterfront is always different than landlocked, and all those things, and so yeah, I think there's a lot to embrace in the local nature of no, one survey is not the right thing for everybody, and we have to be self-conscious of that. May I go all the way back to Akbar's AI stuff?
Of course.
Thank you. Emily and I just submitted a proposal a little while ago using AI to help us link the errors created by survey data collection and their influence on causal inference. The specific problem we chose, no, I guess maybe it's the solution to a problem we would have done anyway. Major depressive disorder, which is more my turf, and ADRD, which is more of your turf, and linking, are they causal or not? And there are a lot of, the problem with survey methodology is it identifies at least 15 different things that can go differently in each interview with two people who live in the same house. So, it raises a lot of different issues about how our data are constrained. And Akbar, I'd say we're hopeful that AI will help us. But yeah, I love your point. Thank you.
Thanks, Bill. I think Ken has to say.
Quick point, which I think is obvious, but important, which is not only, as you were saying, do we need to consider differences within the local environment and Bill was saying for the survey instrument itself, but also are there groups in the local area that are less likely to get into our studies, and sort of the sort of important to understand the selection biases that all of our studies have. Again, if there are certain groups that are more difficult to enroll or drop out more quickly. Just in the dementia research world, there's always this issue of sort of what we in the United States call nursing homes. What's the likelihood that someone with dementia moves into a nursing home where it's typically harder to enroll people and understand what's going on there? There's also different ethical, regulatory issues about studying people in nursing homes or group homes too. So I think that making sure to keep in our minds, again, this just basic survey issue of who's in our study and who's not, even in the local level, I think is important, as well as across international settings. Also, are there different selection biases that really create problems in doing valid comparisons?
My friend Susan Murphy said all samples of the living are a biased sample. There's a bunch of people that random.
Yep. Just maybe a last quick comment. I read that question completely differently too. Localization versus localization. And when I thought of localization, there's certain cultural ability that we're doing. But I also don't want us to forget, I'm glad we have these kind of panels because they push us to think better, right? Ultimately, we're trying to serve the communities that we're part of, right? To live longer and better lives. But when you think about localization, we should not forget the different sort of external pressures that are also occurring, whether it's election, whether it's violence, whether it's a new pandemic. Those all influence whether, we're going to be studying aging when potentially the population may not be able to age because of all those other external factors, right? And these are opportunities where we do have these large studies to be able to adapt to what is happening locally, whether it's the election, whether it's the violence, whether it's the gut. And as you know, I think as a gastroenterologist, everything you eat will dictate your entire life. That's my bias. But the reality is that we should be flexible and adaptable as we do these studies because we're culturally aware, we have trust in the populations aware, and we need to be responsive to their needs at that time. I worry about, what cancers are emerging because we're living longer. And if you're going to die before the cognitive element is going to take place, then we should be aware about those needs. And so just one of those things that I'm trying to push us to think through also.
That's great. Thank you. As we kind of move to the last phase of the panel, I wanted to shift gears a little bit and talk about issues like funding and partnership building. And this partnership that really underlies LOSHAK is a rich partnership with a lot of mutual respect and reciprocity, and emerged out of discussions that the Center for Global Health Equity was really facilitating about 6 years ago now at this point. And I thought, Anthony, I'd like to ask you if you could just reflect on what U.S.-based collaborators, and let's some country collaborators, U.S. Can do better cultivate critical, strong partnerships both.
Yeah, maybe just first of all to mention that, as you said, this collaboration between the Aga Khan University and the University of Michigan started 6 years ago. I think it was the former director of Center for Global Health Equity, that was Joe. I think they had known then Provost Carl Amrain, and they kind of like thought, how do we work together? Yeah, and I think from the very, very beginning, the approach was actually not to develop an MOU at a very high level and sort of like say we want to move to this direction. Yeah, I think the way it was built from more or less ground up. Yeah, they actually brought faculty together with their stewardship, and Akbar, thanks to him, he was part of those discussions. And I think being Kenyan, he was very passionate about doing work in Kenya. And I think when you bring people who are actually going to be the drivers of whatever collaboration, rather than from top down, when you bring people who are actually going to do the actual work together, I think organically they find ways of working together because, first of all, this passion of doing good work, good science. in low and middle income countries amongst all the team members that were brought together. Yeah. So there was passion, and people were really raring to go. Even before the formal structures would catch up, people were already discussing ideas, and people are actually working together in very equitable ways. Yeah. So the structure that comes from the administration actually latches on to that. Yeah. That is, there are people who are looking at each other as colleagues, as equals, intellectually and in every other way. Yeah, everybody has something to contribute. Yeah, we have our context knowledge. You have maybe more advanced experience and skills in, for instance, that time we were working in the area of data science. But recognizing that everybody has something that they're bringing on board, we are equitable. And in all the studies and all the projects that we've actually built together, it's been a core MPI sort of model approach, honoring that recognition of equity. Yeah. So for instance, in LOSHAK, Josh and I, who are MPI, we actually co-leads in each and every dimension, whether it's science, whether it's administrative and everything else. We consult, and then, as equals. Yeah, it's not like we are an implementing partner for the University of Michigan. Yeah, the same goes to our local partners, as you mentioned earlier. That is National Bureau of Statistics, Kenya Medical Research Institute, Ministry of Health. Yeah, they're actually not just partners who are helping us implement the study. They were involved from the very beginning, conceptualization and the design of the study. They sit in our meetings, every management meetings, every Monday, that they get to partake and contribute to the decisions that are being made on how we run the study. In fact, we recall even when we were conceptualizing the R1, we went with Muthoni to Kenya National Bureau of Statistics, and we actually did a presentation. We had these big grand ambitions about doing a national study, and I don't know whether they laughed at us because we had very, very different ideas. For instance, we are actually not even factored the component of pilot. We thought the pilot that we were doing in Kilifi would be adequate to actually enable us to run so they actually contribute on an equitable basis from an intellectual perspective. Yeah. So the other one is for the studies that we've done together with the University of Michigan, there's been a very, very strong component of capacity building for our colleagues. Yeah. A number of them have actually come here to the University of Michigan to learn data science skills, for instance, from the Ozima project. And within LOSHAK, we have a very, very huge capacity building component. Yeah. So the partnership has been equitable, I would say, in all ways, at all levels. And I think this is a model of how we need to build North-South and even South-South partnerships. Probably maybe we should sit together and think of how can we write this up to, show that global health partnerships can work, actually. Yeah, thank you.
I think that was so well said. And actually, one of the last things you said resonates, sort of above all. It's a partnership, and it actually doesn't matter that it's a North-South, South-South partnership. It's just a partnership, right, between people who see each other as intellectual equals. And there's no divide between implementation and intellectual, right? It's all done together as one cohesive partnership. And I think that's really, really paramount. Ken?
I just say that to that, again, thinking back to the early meetings that we had, thinking about LOSHAK as a possibility that, again, I think Anthony, Josh, the team has been, literally the model for what we've tried to do in other parts of the HRS and HCAP network. I think, as you said, Anthony, there's just been such great respect for other opinions and bringing together local knowledge that we don't have here, and again, sharing this expertise. It really has been the model that's worked out incredibly well, and how we'd like them all to work out in the network. I will say, just to not to rain on the parade here at the end, but obviously it's incredibly challenging right now to sort of navigate what's going on in the NIH and the National Institute on Aging, sort of the strangest, disconcerting environment in my 25, 30-year career or whatever. So I think, yeah, continuing to try to keep these conversations going and trying to navigate the much, at least to me, much more challenging current environment and sort of the uncertainty about going forward. We'll have to redouble our efforts to keep talking together, I think.
Absolutely. And maybe that's a good segue. If you want to comment, or this is also something Lindsay and I have spent a lot of time talking about strategies that researchers today can use to make a case for global health and specifically global aging research in an NIH funding climate that may prioritize relevance to US health. How can we make the case that it's important there?
Sure, to Lindsay.
Yeah.
I mean, I'm not the expert. I don't think anyone is. And I think the NIH environment is changing very rapidly. I mean, so what I say now, knows a couple of months from now or a year from now. But I guess like the specific experience that I've had and that several of us have had over the past year with new grant applications going forward is with this new PF5 mechanism for international partnerships, right? And that mechanism is very explicit that there needs to be a domestic US-based institution as the prime institution. You can still have an MPI project between, someone at a US institution and someone at a non-US institution. There can be multiple institutions involved. You can have large consortium. But so within that sort of overall structure, I think there's actually a lot of opportunity because the mechanism is so broad, it's very modular, it's very open. If you actually sit down and read it, it's very open with respect to the type of research as well as infrastructure and training activities that can be written into it. I think there's actually a lot of opportunity for new work to be designed really innovatively. I think that's something that LOSHAK doesn't necessarily need to worry about right now. You're sort of, funding like in the early stages of the funding cycle, which is really nice. But I think, it's hard to predict what things will be like by the time LOSHAK goes up for renewal. Like maybe the PF5 will be gone. I doubt it. I have a feeling like this is going to be the structure going forward, and like LOSHAK may have to be converted. But by that point, I think that the mechanism will be refined and specified out where it needs to be specified, because I think, my team and other teams ran into some roadblocks while trying to prepare these for the first cycle. So the very first cycle of PF5s just passed. It was last month. And we'll start to learn from experience. And one thing Ken and I are thinking about is kind of like what's a coordinated way that we can bring together the HRS and HCAP network members to think about and strategize on submitting PF5s. Like what's the sort of common angle and framing, and how would we want to structure these teams? Like we're figuring it out right now, but I do think there's a couple of ways to like make that case for why doing research outside of the US is valuable to the US, right? And I think the specific, again, this is a local, like a localization versus harmonization tension. I think what that argument looks like is going to look different in different country and like regional contexts, as well as for different like health problems. Thinking about, LOSHAK and kind of the international network, I think, and again, our program officers have advised, like, you cannot overdo it with stating the relevance to US health. Like, you just sort of have to say it again and again and again. I think leveraging contexts, environments, exposure distributions, outcome distributions that differ from the US, and like, what can we learn from a context where things are different, and then apply it back to the US. I think that's a really good example. And I would suggest everyone here, I've been actually thinking about this for a long time. There's a sort of a key paper in social epidemiology by Jeffrey Rose, who was a physician in the UK, sort of active in the 70s, 80s, 90s. And he wrote a seminal paper in social epidemiology called Sick Individuals and Sick Populations. And yeah, some people are nodding. That paper was just absolutely seminal, in which he talks about like when you are a physician, you're sitting there and the patient comes in, and I'm not a physician, like the causes of that individual case are likely going to be very different from the causes at a population level. Like, what does it take to shift the distribution at the population level versus prevent an individual case, right? And so he sort of gives there's a wonderful figure that shows the distribution of hypertension, I think it's hypertension, in British civil servants. This is coming from the Whitehall study, which was sort of a famous panel study in the UK that followed British civil servants and their health outcomes, versus the distribution of hypertension amongst Kenyan nomads. And like the distributions were just wildly different, right? So you have to ask what it is about the contexts that people are living in, between these two places, not what determines an individual case of hypertension, right? And you can only learn about what causes the difference between these distributions when you have cross-population data, right? And then he goes on to talk about interventions that are based on this perspective, and whether you take the population approach, do you try to shift the distribution for the entire population, so design a population-wide intervention, or do you target high risk and bring the tail of the distribution down? So I think a lot of my thinking over the last few years has been informed by that work, and I think it's even more relevant now, given that we need to make the case for why doing international health work is relevant to the US. So highly recommend going to read that. So I think thinking about, specifically to Kenya, what are aspects of the context, whether that is social, economic, environmental, or otherwise historical, and what can be learned and applied to the US. And that can also trickle down to differences in exposure and outcome distributions within the population. So again, not one specific guideline, but that's going to look different. And I think that there are like really strategic arguments that can be made. And I think doing that really thoughtfully means that there needs to be really meaningful partnerships with co-creation, because like a US-based team is not going to be able to do this alone, right? Like this needs to be co-created. And then another argument is it's just simply good science, right? And one of the first things we learn in epidemiology is that we describe the distribution and determinants of disease outcomes by person, place, and time. And like we all know in science that replication is essential for causal inference, right? And so we do need an evidence base that replicates findings across populations, across time periods, in order to draw inference and strengthen inference, right? Like the US is not an island. Like we cannot draw causal inference based on studies in the US alone. So that's sort of my 2 cents on this. Talk to me in a year, it'll probably change. Yeah, I mean, who knows?
Great, thank you. Akbar, I know at the Center for Global Health Equity, we've also thought a lot about this sort of global, local dynamic. Anything that you could add about that?
I also work for federal government, and I see needs at both, the veteran population level, at the rural community level. And I think you and I, Josh, have talked about this. We talk about global health, and reflexively people think low middle income countries, right? Even if you flip those words and say health globally, it has a completely different connotation. And I like us to think like that local global aspect is really, how do we think about health globally? We're all citizens of this world. And now, however, no matter how corny that sounds, I truly believe that, right? That we need to be really thinking through all the populations, vulnerable populations that are potentially at higher risk. And how do we think about this more universally?
Great. And what if you just pass the microphone right there to Muthoni? And Muthoni, we're coming up on time here, and I was hoping you could just give us with some closing thoughts about, sorry, it's a lot of pressure there, but I know this is a challenging time globally when we think about science and attacks on science and the credibility of science being questioned sort of publicly. This is challenging. So what gives you hope? What do you, how do you surmount that personally, but also professionally?
Interesting question, because again, today we've talked about how we do things in a certain context and how that is interpreted in that context. And as Lindsay was talking, there's something that crossed my mind about what it is that, like trying to say, how do I benefit if I am in this context from another different context? And I'd just like to talk about this, for example, from a cognitive point of view, where we talk about certain people in certain contexts being more resilient, and we don't talk about that resilience that has been built over time. And there's a possibility that that's the reason why cognitive decline is not as common as it should using a certain standard. and also to what has just been said, global health globally. These days, boundaries are limited, as in there's no limitation to boundaries. And if we're going to address the health of people, we're not only addressing health of people who have been originally, or who were originally, whatever original means. So we have to take care of everybody else with all the cumulative things that they have carried from all other places that they have come from or been through. So when we talk about research, how do we apply and what do we apply in what context, and how do we interpret it for credibility purposes? So it is an interesting, I don't have an answer to that, and I just want to ask all of us that question. And when we talk about research, what exactly are we doing that research for? What are we looking for?
No, that's great. You've left some interesting thoughts and to discuss over our upcoming dinner. And I'll just close by thanking everybody on the panel, as well as the people who are here with us today and people who in the future will be viewing this. I think this is a really rich discussion on population aging in Kenya and in other low and middle income settings. And just to say that, you know, these sorts of conversations, even in a time that's challenging, where we do have some of these hurdles or some of these challenges to surmount, these kinds of conversations personally give me a lot of hope and are the thing that keeps driving me. And so I hope we continue these conversations both at dinner, but also as time goes on. And again, thank you to our colleagues for being here and to everybody who participated.